Setting posterior denture teeth. Basically, anterior denture teeth are set for aesthetics and phonetics, whereas posterior teeth are set for function. There are many ways of setting denture teeth, and we refer to these as philosophies of denture occlusion because there is no scientific studies that show one is clearly superior to another. At Dalhousie, we will basically choose one of two occlusal schemes based on clinical experience. These two occlusal schemes are lingualized articulation and monoplane articulation. Both of these occlusal schemes are attempts to stabilize dentures, which can move, tilt, tip, causing loosening or pinching on the mucosa. In lingualized articulation, we use contacts from the maxillary lingual cusp to center on the mandibular ridge to help minimize movement of the dentures. In monoplane articulation, the elimination of cusps helps to minimize lateral forces on the denture. In the lingualized occlusal scheme, in centric, the maxillary lingual cusp is the only contact with the central fossa or marginal ridge of the opposing mandibular tooth. The lingualized occlusion has an advantage in regards to appearance because we use cusp teeth in the maxillary arch. This looks more natural. In general, for lingualized occlusion, we set either very little or no anterior vertical overlap, which is sometimes referred to as overbite. Lingualized occlusion has been described either with or without non-working, or sometimes called balancing contacts in excursions. At Dalhousie, we will attempt to establish some non-working contacts in excursions. And generally, for all occlusal schemes using a lingualized occlusion, anterior teeth should have some contacts in excursions. In general, in the maxillary arch at Dalhousie University, we will choose a maxillary anatomic denture tooth with a 33-degree cusp angle. In the mandible, we will choose denture teeth depending on the condylar guidance. If the condylar guidance is steep, we will choose an anatoline or 10-degree cusp tooth, and if it's very shallow, we will choose a non-anatomic tooth such as the portrait 0-degree tooth. There are many denture occlusions other than these two that we have described here, but for our purposes, we will choose lingualized occlusion or the monoplane occlusion. There are a number of ways to set denture teeth, but in general, if we are setting the mandibular teeth first, for a lingualized occlusion, we will set the mandibular teeth, the posterior teeth, the premolars, and the molars level with the occlusal plane and centered over the mandibular ridge. This is the area where we want the maxillary lingual cusp to contact. For a balanced lingualized occlusion, such as we will try to design at Dalhousie University, in centric, we want to establish simultaneous bilateral posterior contacts. In other words, that the maxillary lingual cusp is in contact with the central fossa or the center of the marginal ridge of all posterior teeth. In excursions, we would like to establish bilateral contacts of the posterior teeth, that is the maxillary lingual cusp, and the anterior teeth, so denture does not displace or tip during function. Some mandibular tooth forms have been designed for use with a lingualized occlusion. One such mold is the Dentsply and anatoline molds. These can be set with little or no curve of Wilson. The lingual and buccal cusps of the mandibular teeth should be set level with the plane of occlusion. The second molar is often elevated by approximately 15 degrees from the occlusal plane, and the maxillary lingual cusps are set so that they contact the central fossa or the center of the marginal ridge, and that 1 millimeter of space is left between the buccal cusps of the mandibular and maxillary teeth. Once our centric relation position has been verified, it is important to ensure that there are no maxillary buccal cusp contacts in both centric and lateral excursions. In lateral excursions, there should be working contacts of the maxillary lingual cusp. Similarly, the anterior teeth should be in contact during these excursions. If you look at the bottom right photo, you will notice, however, that mandibular and maxillary buccal cusps should not be in contact in these excursions. For a balanced lingualized articulation, such as we desire to establish at Dalhousie, you should see non-working contacts in excursions. Again, these should be the maxillary lingual cusp against the mandibular buccal cusps. To keep posterior teeth in contact in excursions is more difficult than it might first appear. To understand this, let's take a look at what happens during downward movement of the mandible during excursions. Take a look at the photos or the pictures on the left-hand side of this screen. If we had no cusp height at all, if we had no cusps on the teeth, and we had a condylar inclination and an anterior guidance that had some sort of positive angulation, that when we moved into protrusion or lateral excursions, the condyle that was translating would tend to cause the posterior teeth to separate. In other words, as the condyle moved forward, it would have to move downward along the glenoid fossa, and the anterior teeth would have to slide and move apart. And if there were no cusps in the posterior teeth, these would separate. As you can see on the right-hand side, if we introduce some cusp angle to these teeth, then we may be able to continue to have contact of the posterior teeth in excursions. Here's an example on an articulator. Take a look at the effect of condylar guidance here. In the top photo, as we come into protrusion with a very shallow condylar guidance, you can see that the anterior teeth and the posterior teeth are both in contact. If we steepen this condylar guidance dramatically, you can see that as we go progressively from the top photo down to the most steep condylar guidance at the bottom photo, there is more separation of the posterior teeth in excursions. This is referred to as the Christensen's phenomenon. There are a number of methods to help us maintain non-working contacts in excursion. One of these is to change the angle of the occlusal plane. The more tendency towards separation of the mandible, the steeper the occlusal plane angle needs to be in order to maintain contact. As dentists, when we set the occlusal plane with our wax rims, we have some control over this. A second technique is to use a compensating curve, so that posterior teeth on a curve tend to maintain a posterior contact in excursions. A last method is to introduce cusp angles, and that the steeper the cusp angles, the more contact there will be in the posterior teeth. Remember that as dentists, we can record the condylar angulation with the protrusive record, but we have no control over what that condylar angulation is, because that's an anatomical determinant. The cusp angle of the denture teeth can be selected by the dentist, and we can have some control over that. There are a number of ways of checking for a balanced articulation, such as articulating paper. Intraorally and on the articulator, another method is to place a finger and thumb on the maxillary canines, have the articulator or the patient move in excursions. Those excursions should be smooth if you have an acceptable balanced articulation. If you feel jumps or bumps, those are normally due to cusp tips moving up and over the cusp tips, inclines, or marginal ridge of the opposing teeth. Even if posterior teeth are as set as well as they could be, almost every setup will require some occlusal refinement, sometimes called occlusal adjustment or selective grinding. So we set the teeth as close as we can in maximum intercuspation, with the maxillary lingual cusp centered over the mandibular arch, and then try to attempt balanced articulation. Almost all setups will require some adjustment, and we'll go over some rules to help you do this. When analyzing contacts using articulating paper, the IF or IIF rule may help you analyze what you are looking at. IIF stands for the inner inclines of functional cusps. Those are always non-working contacts. If you look at this picture, you'll notice that for both the buccal and the lingual cusp, if you look at the cusp tip, there is an outer tooth incline rising up towards the cusp tip, and there is also an inner incline rising up to the cusp tip for both of those cusps. The outer inclines here are marked in red, and the inner inclines are marked in green. When we look at the tooth from the occlusal view, the functional cusp is always the centric cusp. So in the mandible, that would be the buccal cusp. In the maxillary arch, that would be the lingual cusp. If you look at the picture on the right-hand side, you'll notice two working contacts. The upper one on the buccal cusp is on the outer incline of the functional cusp. That's not the inner incline, so that's a working contact. If you look at the lower working contact, that's on the inner incline of the non-functional cusp. So that's not a non-working contact either. Both of those have to be working contacts. In a normal class 1 occlusion, only those contacts on the inner incline of functional cusps are non-working or balancing contacts. The if rule helps you analyze whether you're looking at a non-working or a working type of contact. There are also rules for denture setups in order to establish what are good types of non-working contacts. In general, non-working contacts should be lines and not points, and they should never be heavier than the working contacts on the opposite side of the arch. Let's take a look at a few examples. I'm going to ask you to find the non-working contacts in these examples. In this particular case, we are looking at a mandibular molar, so that we know that the non-working contact is on the inner incline of the functional cusp. Functional cusp here is the buccal cusp, and the inner incline of the functional cusp is the only contact that is a non-working contact. If we look at these lines here, this is a maxillary molar, and again, the non-working contact is only on the inner incline of the centric cusp, the functional cusp. All the other contacts that could be made here would be working. What type of contact do you see here? If you guess that that is a non-working contact, those red lines are. The red dots are the centric stops, and someplace between the centric stop and the line, there is a cusp somewhere else in the arch that is separating this tooth. But in general, these are good types of non-working contacts for a balanced articulation. Here's another example. What type of contacts do you think this is? If you guessed that this is a working contact, you are correct. This is a mandibular molar, and any non-working contacts would be on the inclines of the buccal cusp. These are on the inclines of the non-working or non-centric stop, so these have to be working contacts. Remember, only inner inclines of functional cusps are balancing contacts. All others are working. What type of contacts do you see here? Let's start by looking at the central fossas. You can see two orange-reddish dots. Those are our centric contacts. Contacts lower than the central fossa in this photo are working contacts. They are on non-functional cusps. They can't be on the functional cusp, so they can't be working contacts. On the upper portion from the central fossa, you can see a number of contacts that are starting to be lines or short dots. Those are on the inner inclines of the functional cusps, the buccal cusp in a mandibular molar, and therefore those would be non-working or balancing articulating contacts. Try to guess what all of these contacts are here and see if you agree with some of your neighbors. As we can see, when we start to look at articulation of a full arch of denture teeth, picking out the excursive contacts can become confusing. If you stick to the IIF or if rule, inner inclines of functional cusps, all you need to know is that any contact on the inner incline of a functional cusp is a non-working or a balancing type of contact. You should try to mark your centric stops and excursions in different colors so that you can identify where centric contacts are and where the excursive contacts start and end. The whole idea of the lingualized occlusion is that the maxillary lingual cusp will act as a mortar and pestle type of occlusion against the mandibular teeth. We should look at how the anterior teeth are set more closely. Normally, if we have a class 1 type of jaw relationship, there should be 1.5 to 2 millimeters of horizontal overlap, sometimes called overjet, of the anterior teeth. If we have a patient who has a very class 2 skeletal type of angle classification, there may need to be a little bit more horizontal overlap. For class 3 skeletal patients, we may have little or no overjet. And remember, we're trying for very little or no overbite. Remember, in the posterior portion of the arch, in centric, we want to make sure that there is overjet, so that there is no buccal-to-buccal cusp contact of the posterior teeth. In fact, we want some space, at least 1 millimeter, between the buccal cusps in centric position. The horizontal overlap is important. That will prevent cheek biting or lip biting. Also remember that we want to stop setting teeth when we get to the ascending portion of the ramus. In other words, denture teeth should be set mostly on the horizontal aspect of the residual ridge. We have spent a bit of time discussing lingualized occlusion. Now let's discuss some of the aspects of monoplane occlusion, the other type of occlusion that we use at Dalhousie in order to stabilize dentures. A monoplane occlusal scheme is basically taking cuspless teeth, 0-degree cusps, and setting them on a flat plane. Normally we would set 1.5 to 2 millimeters overjet, similar to what we would do in the lingualized occlusion. There would be no cusp to fossa relationship because remember, there are no cusps. There are no anterior contacts, again in centric position, similar to the lingualized occlusion. The philosophy of the monoplane occlusion is that by eliminating cusps, we reduce lateral forces on the denture and help to improve denture stability. It's also being proposed that this type of tooth arrangement is much simpler for people to establish. Setting no overbite helps to prevent tipping caused by contacts of the anterior teeth in excursions. Similarly, an overjet of 2 millimeters is used to create an illusion of the overbite. In excursions, in a true monoplane occlusion, as the patient goes to an excursions, if there is any condylar inclination at all, this will tend to cause some separation of the posterior teeth, as we saw in our examples earlier. Remember that as the condyle tries to come forward, it will be forced down the angle of the glenoid fossa, and the steeper that condylar inclination is, the more separation there can be of the posterior teeth. That's why we won't want to set too much anterior disclusion when we set up the denture teeth, and that's why we set up no overbite in excursions. It will depend on our condylar inclination how much separation we have of posterior teeth, and we have no control over that because that's an anatomical determinant. So as you see in these two photos, as the patient goes into excursions, there should be contact on the working side, but there may not be any contacts on the balancing side, depending on the steepness of that condylar inclination. With a monoplane occlusion, when the teeth are flat and set on a flat plane, the anterior teeth will make contact in excursions. Sometimes this can cause tipping of the denture, and some people have proposed modifications to the monoplane occlusion to help us gain some contact in excursions on the posterior teeth. Some of that is to create balancing ramps or a curve of spee in the occlusion or compensating curves to help maintain a posterior contact for maintaining stability on the denture. To understand what is happening in the posterior occlusion, let's pretend for a moment we don't have any condyles and we don't have condylar inclinations to deal with. When the patient goes into excursions, it would simply be sliding from side to side, and the posterior teeth would stay in contact during that time. See, as it moved here, we would just have contacts on both sides as the patient moved over to the left side, as we see in this diagram. If we do have condylar inclination, as the patient moves, you can see that on the side where the condyle is translating, it will have to move down the glenoid fossa, and the side that's the non-working side, there would actually be separation of the teeth in a lateral excursion. Similarly, in a protrusive arrangement, we would see that the teeth would separate probably on both sides, depending on what the condylar inclinations were on opposite sides. There are a number of advantages of using a monoplane occlusion, and some cases where we actually prefer to use a monoplane occlusion. Technically, this type of occlusion is easier to set, and it does minimize lateral forces. If we have difficulty obtaining a repeatable centric record, setting up a cusp to fossa relationship becomes very difficult. If the patient has muscle incoordination, we may also find that it's difficult to repeat centric records. In this case, having teeth with no cusp makes it easier to set up the occlusion in case we make an error in selecting the proper centric position. When patients have severe skeletal malocclusions, class 2, as you see in this photo, or a severe class 3, again, not having cusps that need to be set into fosses may be advantageous and may be easier to set up. Similarly, when we have severe residual ridge resorption, trying to maintain teeth on either side of the arch will cause the denture to move no matter whether there are cusps or not, and not having cusps will put less lateral forces on the denture and help keep the denture stable. Some dentists believe that the monoplane occlusion is a panacea for all cases, but there are some disadvantages to using a monoplane occlusion. For most patients, the maxillary teeth having no cusp results in a poorer appearance. And if the patient has a very steep condylar guidance, there's going to be a huge separation of the posterior teeth with potential tipping of the denture caused by the anterior disclusion of posterior teeth. You should always take a protrusive record prior to setting denture teeth, whether you're using a lingualized or a monoplane occlusion. Some people don't think it's important with a monoplane occlusion, but the condylar inclination will affect how much separation there is of posterior teeth. Therefore, it is important to see how much there is on the articulator. Also, for monoplane occlusion, at the delivery appointment, we will always do a clinical remount on the articulator. That will give you practice in doing a clinical remount. Adjusting a monoplane occlusion is different than adjusting a lingualized occlusion. The main adjustment is to keep the surface of the 0-degree teeth flat. So we would use a flat-sided burr and try to obtain as even a contact bilaterally as we can. If there are heavy prematurities near a fossa, we could shallow that out a little bit, but again, we would like to keep the flat surface on a flat plane in order to limit lateral forces on the denture. To complete today's discussion on setting posterior teeth, you should take a look at these videos on our Dalhousie removable prosthodontic website on the videos page. There is a set of videos on setting denture teeth, and you'll find these videos under that separate page.